Welcome to the deep dive. Today, we're tackling a really foundational area for you fundamental nursing students,
That's right. We're looking at the male and female reproductive systems.
and specifically that amazing hormonal orchestra that keeps them running.
Yeah, it really is like an orchestra. We've pulled together a range of resources to, really get to the heart of how these systems work.
Good.
Our goal here is to give you a clear, engaging understanding of the key concepts, the stuff you'll actually use in your nursing studies.
Without getting bogged down in like super tiny details.
Exactly. We want you feeling informed, confident, but not overwhelmed.
Perfect. Okay, so where should we start? Female system.
Sounds good. Let's begin with the female reproductive structures. Think ovaries first.
Right, the ovaries. They store the ova, the eggs.
But they're more than just storage. They're dynamic endocrine glands. They produce estrogen and progesterone right there inside those little sacs called follicles.
Okay, so hormone factories, basically. And then the fallopian tubes.
Vital passageways. They're muscular, lined with these tiny hair-like things, cilia.
Cilia.
And their job is to gently sweep the ovum once it's released, down towards the uterus.
And the uterus itself, that's where the embryo or fetus develops.
Precisely. It has that inner lining, the endometrium, which is crucial for implantation.
And powerful muscular walls for childbirth, obviously.
Absolutely. And then you have the accessory structures.
Like the vagina, clitoris, labia.
Correct. And also the breasts. While maybe not directly involved in reproduction itself, they're heavily influenced by these hormones.
And essential for nourishing a newborn, of course.
Definitely. Now, maybe we can pivot to the male system.
Sure. So the testes.
Yeah.
Kind of the male equivalent of ovaries.
You could think of it that way, yeah. They produce sperm inside these tiny coiled tubes, the seminiferous tubules.
Okay.
And they also make that key male hormone, testosterone.
Right, testosterone. Where exactly is that made?
In specific cells called interstitial cells, or you might hear them called Leydig cells. They sit between the seminiferous tubules.
Leydig cells. Got it. And like the ovaries, the testes respond to signals from the brain.
Exactly. They're responsive to FSH and LH from the anterior pituitary.
Okay, so FSH and LH are important in both males and females.
Very much so. Then you have the vas deferens.
For sperm storage and transport.
And the prostate gland, adding enzymes and fluid. The penis for delivery, and the urethra.
Which has that dual role, urine and semen.
Correct. What's really fascinating, though, is the origin.
Oh.
The actual hormone-producing tissues in both males and females, they start from the same embryonic tissue.
Really? So they differentiate later?
Exactly. They differentiate and migrate to become either ovaries or tests, but they share that common beginning.
Oh.
And as we said, both respond to FSH and LH from the pituitary. It highlights this fundamental similarity in how they're regulated.
And the pituitary isn't acting alone, is it? It gets its orders from higher up.
That's right. The hypothalamus in the brain releases gonadotropin-releasing hormone, GnRH.
GnRH.
So the whole cascade starts in the brain. Hypothalamus talks to pituitary, pituitary talks to gonads, ovaries, or testes.
That top-down control seems like a really key principle.
It absolutely is. So shall we dive deeper into the hormones, maybe starting with the female system again? Estrogen and progesterone.
Yeah, let's do that. Estrogen first. I know there are different types.
Right, like estradiol, estrone, estriol. But collectively, estrogen, mainly from the ovarian follicles.
And it does a lot, doesn't it? I mean, developing female characteristics, genitalia growth, breasts.
The pattern of pubic hair, even protein building in the body.
And it affects cholesterol levels, too.
It does. Generally increases total cholesterol, but boosts the good HDL. It also causes sodium and water retention.
Which can be important maybe during pregnancy for blood volume.
Exactly. And critically, it inhibits calcium breakdown in bones.
Ah, that's the link to osteoporosis after menopause, right? A key thing for nurses to know.
Absolutely crucial. It also widens the pelvic bones, helps close the growth plates in long bones.
So it signals the end of height growth.
Essentially, yes. And there's more.
Wow.
Increases thyroid hormone globulin, affects skin elasticity, blood vessels.
Makes the uterus more motile around ovulation.
Yeah, to help sperm and egg meet. And it thins the cervical mucus.
Making it easier for sperm to get through.
Right. Plus, it builds up that uterine lining, the proliferative endometrium, and it even has an anti-insulin effect, making sure glucose is available.
And dampens the immune system a bit.
Kind of modulates T-cell activity, possibly to help prevent rejecting a potential pregnancy. It's a real multitasker.
No kidding. Okay, what about progesterone?
Progesterone comes mainly from the corpus luteum. That's what's left of the follicle after ovulation.
Okay, the corpus luteum, and its main job is pregnancy support.
Pretty much. If estrogen gets things ready, progesterone helps maintain a potential pregnancy.
So it calms the uterus down, helps with implantation.
Exactly. Decreases uterine motility. It also develops the uterine lining further, making it secretory-rich in nutrients.
And it thickens the cervical mucus.
Yes, creating a kind of protective plug.
Okay. Other effects.
Contributes to breast growth, raises basal body temperature.
The basis for temperature tracking for ovulation.
Correct. Can increase appetite, also modulates immune function, and has an anti-insulin effect, too.
So both have complex roles. How does the body, control all this? It seems like a delicate balance.
It absolutely is. It starts back at the hypothalamus. At puberty, it begins releasing GnRH, but in pulses.
Pulses, not just a steady stream.
Right. That pulsatile release is important. That stimulates the anterior pituitary to release FSH and LH.
Okay. GnRH, pituitary, FSH, NLH, then those travel to the ovaries.
Correct. They stimulate the follicles to grow and mature. And as the follicles grow,
They produce estrogen.
exactly, estrogen levels rise. Eventually, they hit a critical point.
And that triggers.
A big surge of LH from the pituitary. The LH surge, that's the key event for ovulation.
Ovulation, the egg is released, and the LH surge also forms the corpus luteum.
Yes, from the remnants of the ruptured follicle.
And the corpus luteum then makes both estrogen and progesterone. It's like a sequence.
A very carefully timed sequence. Now, here comes the feedback part. Negative feedback.
Okay, like a control mechanism.
Precisely. High levels of estrogen and progesterone coming from that corpus luteum signal back to the hypothalamus and pituitary.
Telling them to slow down?
Essentially, yes. They inhibit the release of GnRH, FSH, and LH. This prevents new follicles from developing during that cycle.
So it keeps things focused on the potential pregnancy for that cycle. This feedback idea seems universal.
It's fundamental in endocrinology, yes. Keeps things in check. We'll see it in the male system, too. Self-regulation.
Got it. Like a thermostat. But what if pregnancy doesn't happen?
Good question. If there's no fertilization and implantation, that corpus luteum has a limited lifespan, maybe 10 to 14 days.
And then it just breaks down.
It degenerates, yes. And when it does, estrogen and progesterone levels plummet.
So the brake comes off the hypothalamus and pituitary.
Exactly. The inhibition is removed, GnRH release starts up again, FSH and LH follow, and a new cycle begins.
It really is a cycle. Wow. Now, you mentioned external factors can influence this.
Yeah.
Through the hypothalamus.
Yes, the hypothalamus is quite sensitive. Significant stress, for example, can inhibit GnRH release.
Which makes sense biologically. Reproduction takes energy if you're stressed.
The body might prioritize survival, so as a nurse, you might see stress affecting a patient's menstrual cycle.
So things like starvation, maybe extreme exercise, emotional problems.
Yeah.
They could all impact GnRH.
That's correct. They can decrease reproductive capacity.
And light. You mentioned light earlier.
Yeah, there's evidence suggesting increased light exposure can boost FSH, LH, estrogen, and progesterone. It might play a role in timing puberty.
Fascinating. The environment interacting with our internal hormones. Okay, let's walk through the menstrual cycle phases clearly. Menarche is the start, the first period.
Right. Phase 1 is the follicular phase. Starts with FSH and LH release, stimulating follicle development.
And as follicles grow, estrogen rises.
Correct. And you might see those estrogen effects, breast tenderness, maybe some water retention, thinning cervical mucus.
Then comes ovulation, usually mid-cycle, triggered by that LH surge.
Yep, egg released. And now progesterone from the newly formed corpus luteum starts to play a bigger role.
Which leads into the luteal phase.
Exactly. The corpus luteum is active, secreting both progesterone and estrogen. Progesterone dominates here, getting the uterine lining ready, making it secretory.
Ready for implantation. And this is when you might see that temperature rise, increased appetite, maybe bloating.
Those are common progesterone-related effects.
And then, if no fertilization, the corpus luteum gives up.
After about 14 days, it involutes or breaks down. Hormone levels drop sharply.
Estrogen and progesterone fall, and that triggers menstruation.
Correct. The withdrawal of hormones causes that thickened endometrial lining to shed.
And that shedding is menstruation. What about clotting? Does it just bleed freely?
Well, there's a lot of plasminogen in the uterine fluid, which helps break down clots, preventing large ones from forming.
Okay. And cramps.
Prostaglandins. They're hormone-like substances in the uterus that cause contractions to help expel the lining and constrict blood vessels. Unfortunately, they can also cause pain.
Right, and then the low hormones let GnRH start up again, and the cycle repeats.
Precisely.
Okay, that makes the typical cycle clear. But what if pregnancy does happen? The hormones must shift dramatically. Understanding this must be critical for prenatal nursing.
Absolutely critical. If fertilization occurs, the embryo implants in the uterine wall. Then, the placenta starts to develop.
The placenta, that becomes the main hormone producer then.
Eventually, yes, it takes over, churning out high levels of estrogen and progesterone to maintain the pregnancy, keep the uterine lining stable, prevent contractions early on.
This explains why some interventions focus on supporting hormone levels. And what about that pregnancy test hormone, HCG?
Human chorionic gonadotropin. The very early embryo starts secreting it almost immediately after implantation.
And HCG tells the corpus luteum.
Hey, stick around, keep making progesterone and estrogen. It basically rescues the corpus luteum, keeping it functional for the first few months until the placenta is fully up and running.
So HCG is the signal that pregnancy has begun, and its detection is the basis of pregnancy tests.
Exactly. Understanding HCG is fundamental there.
Okay. And hormones shift again towards the end of pregnancy.
Yes. There seems to be a relative decrease in progesterone's influence compared to estrogen's near term. This might make the uterus more sensitive, more prone to contract.
Preparing for labor. But labor itself isn't just hormones, is it?
No, it's multifactorial. There's the physical stretch of the uterus and cervix.
That can trigger contractions.
It can. Plus, the fetus starts producing more cortisol and prostaglandins, which also ramp up contractions. And then there's oxytocin.
Ah, oxytocin. From the posterior pituitary.
Yes. A very powerful stimulator of uterine contractions. It's a complex interplay.
Definitely sounds like it. What about after the baby is born? Postpartum? Big hormonal changes then too, I imagine.
Yeah.
Vital for nurses to understand.
Huge changes. Once the placenta is delivered, estrogen and progesterone levels just plummet back towards baseline.
That must be quite a shock to the system.
It is, and that adjustment takes time. Meanwhile, prolactin, which was high during pregnancy but inhibited by estrogen and progesterone,
Now it can work.
now it can stimulate milk production in the breasts.
So milk production really kicks in after birth because the hormonal brakes come off.
That's the idea. And then oxytocin comes back into play for milk ejection.
How does that work?
The baby suckling stimulates nerves, signaling the posterior pituitary to release oxytocin. Oxytocin then causes the cells around the milk sacs in the breast to contract, squeezing the milk out.
A positive feedback loop. Suckling leads to milk release, which encourages more suckling.
Exactly.
Okay. Now, let's shift to the other end of the female reproductive lifespan. Menopause. What's happening hormonally, and what should nurses know?
Menopause is fundamentally about the ovaries running out of viable follicles.
So no more follicles means?
A drastic drop in the production of estrogen and progesterone by the ovaries. This leads to the end of menstruation.
And the brain tries to compensate at first.
Often, yes. The hypothalamus and pituitary sense the low estrogen progesterone and ramp up GnRH, FSH, and LH, trying to stimulate the ovaries.
But the ovaries can't respond effectively anymore.
Right, so you might see high FSH and LH levels initially, though they might settle down somewhat over time due to other feedback mechanisms.
And the loss of estrogen and progesterone has consequences. We mentioned bone health.
Big one. Increased risk of osteoporosis due to less calcium retention. Also changes in lipid profiles, potentially affecting heart health.
And other symptoms people associate with menopause.
Vasomotor symptoms like hot flashes, thought to be related to changes in temperature regulation. Vaginal dryness and thinning tissues can cause discomfort and increase UTI risk. Changes in secondary sex characteristics, too. It's a major physiological shift nurses need to understand for patient care.
Absolutely. Okay, let's pivot back to the male system now. Hormonal control there. Testosterone is the star player, right?
It is. Produced by those interstitial or Leydig cells in the testes.
And its effects are widespread. Development of male organs.
Penis, prostate, seminal vesicles, vas deferens, growth of testes and scrotum.
Deepening voice.
Thickening vocal cords, yeah. Hair growth patterns, face, body, though also linked to male pattern baldness.
Right. And metabolic effects. Muscle growth.
Definitely. Testosterone is anabolic. It increases protein building and decreases breakdown. That leads to muscle growth. It also promotes bone growth, length and width, until the growth plates close.
Making the male skeleton typically larger and denser.
Correct. Also, thicker cartilage, skin, vascular thickening, and it boosts red blood cell production, increases hematocrit.
So how's its production controlled? Similar hypothalamic-pituitary axis.
Very similar setup. After puberty, the male hypothalamus releases GnRH.
Stimulating the anterior pituitary to release FSH and LH.
Exactly. Though in males, LH is often called ICSH, interstitial cell stimulating hormone.
Because it stimulates the interstitial cells.
Precisely, to produce testosterone.
Okay. And FSH, what's its main job in males?
FSH primarily targets the seminiferous tubules, stimulating sperm production, spermatogenesis.
Spermatogenesis. Got it.
But FSH also acts on Sertoli cells within those tubules.
Sertoli cells, what do?
They support sperm development, but interestingly, FSH stimulates them to produce some estrogens.
Estrogen. In males?
Yes. And these estrogens provide negative feedback to the pituitary and hypothalamus, helping regulate GnRH, FSH, and LH release.
Wow. Okay. So estrogen plays a feedback role in both sexes.
It does. And the Sertoli cells also produce another hormone, inhibin.
Inhibin. What does that inhibit?
Mainly FSH release. When sperm production is high, inhibin levels rise, telling the pituitary to ease off the FSH. It helps regulate the rate of spermatogenesis.
Makes sense. So LHICSH stimulates testosterone production.
Right. And then testosterone itself feeds back negatively to the hypothalamus.
Inhibiting GnRH release.
Correct. Yeah. Which then reduces FSH and LH secretion. So high testosterone puts the brakes on its own production pathway.
Keeping levels in a relatively stable range. Another example of that feedback loop.
Exactly. Checks and balances.
And light. Does sunlight affect testosterone too?
There is some evidence suggesting, yes, increased sunlight might boost testosterone levels, but the mechanism isn't fully clear yet.
Interesting parallel. Okay, so women have menopause. Is there a male equivalent? Andropause. Is that something nurses should consider in aging male patients?
Yes, andropause, or sometimes called late-onset hypogonadism. It's a gradual decline in testicular function with age.
So the seminiferous tubules and interstitial cells start to atrophy?
Gradually, yes, leading to decreased testosterone production and effects.
Is it as distinct as menopause?
Generally, no. It's usually much more gradual, and the timing and rate vary a lot between men.
But similar feedback attempts initially. Higher GnRH, FSH, LH.
Potentially, yes, as the brain tries to stimulate the declining tests. But if the tests don't respond well, those levels might eventually normalize or find a new set point.
So a more subtle transition overall. Okay, lastly, let's touch on the human sexual response. You mentioned the stages are similar despite the anatomy. This seems important for holistic care.
Very important. The underlying physiology shares a lot. It usually starts with the excitement phase.
Triggered by physical or psychological stimuli?
Both. And it involves the parasympathetic nervous system.
Leading to increased blood flow. Erection in males, lubrication and engorgement in females.
Correct. Vasoactive chemicals like nitric oxide and acetylcholine are key players in relaxing blood vessels to allow that increased flow.
Then comes climax or orgasm.
Right. This involves the sympathetic nervous system, ejaculation in males, rhythmic muscle contractions in females, intense pleasure.
And finally, resolution.
Things return to baseline. Muscles relax, blood flow reduces.
So fundamental similarities in the response cycle itself.
Absolutely. Despite the anatomical differences, the progression is quite parallel.
Well, this has been incredibly thorough, a real deep dive into these reproductive systems and their hormones. It's amazing how interconnected it all is.
It really is. And understanding these fundamentals, the structures, the hormones, the feedback loops is just so vital for your nursing practice.
Yeah, you can see how it impacts health across the entire lifespan.
Definitely. From development, puberty, fertility, pregnancy, menopause, andropause, it touches everything. You'll encounter these principles constantly in clinical settings.
So maybe a final thought for our listeners to chew on as they continue studying.
How about this? Consider how disruptions in these really delicate hormonal balances, too much, too little, wrong timing, how those imbalances can actually show up as different health conditions you'll see in patients.
That's a great point. Thinking about the clinical manifestations of hormonal issues, that really connects this foundational knowledge to practice.
Exactly. Understanding the why behind those conditions is key to providing effective nursing care.